Yes. So, sir, should we start? Sir, should we start now?
Yeah, please.
Okay, so
ma'am,
All experts are there.
sorry to interrupt, ma'am. Can you start with a short Learned video?
Yeah.
Yes. Please start.
Okay, just give me a minute. A very good evening and a warm welcome to one and all present here. I am Debulina, the designated moderator from Clearnet site, and we are very much proud to be a part of this webinar as a digital partner. So with all of you now, I am going to share a short glimpse of Clearnet. Our website is www.clearnet.com. There we have lots of live sessions conducted by eminent speakers across the globe. Besides, we have MedWiki services, which is medical Wikipedia for doctors only. So we will invite all the doctors to visit our website. And now, without further delay, I would like to hand over the session to Dr. Nehal Patil, ma'am, to start with our today's session. Over to you.
All, welcome to our Pathshala PG Clinic. Today we have a PG case discussion, and for this we are having renowned experts with us. So I welcome Dr. Jitendra Meena sir, who is at present an assistant professor at Division of Nephrology in the Department of Pediatrics, AIIMS, New Delhi. And sir's area of interest is acute kidney injury, nephrotic syndrome, and UTI. He has major achievements in his hand, that Fellowship of the National Academy of Medical Science 2022, in fellowship by the Indian Society of Pediatric Nephrology in 2016, and Best Paper Award at Con in 2021. He has more than 50 of publications. Welcome, Jitendra Meena, sir. We also have other faculty, which is very renowned. So, Dr. Kara, she is in charge Pediatric Nephrology Unit of Department of Pediatrics at PGI MER Chandigarh, and she is instrumental in developing the Pediatric Nephrology Unit at PGI with a dedicated hemodialysis facility for children. Also instrumental in starting the DM program in pediatric nephrology. She has around more than 60 papers published in national and international journals. Welcome, Kara ma'am. We also have one more expert this time. So we welcome Dr. Christy. Dr. Christy Thomas. She has done her MD Pediatrics from the Government Medical College, Thiruvananthapuram, Kerala, and DM Nephro from AIIMS, New Delhi. Her area of interest is pediatric cystic kidneys and dialysis. Her affiliation is as an assistant professor in the Department of Nephrology at SAT Hospital, Government Medical College, Thiruvananthapuram, Kerala. Welcome, Christy ma'am. We have today our presenter, Dr. Naresh Rathwar, who is present at the Narendra Modi Medical College, Ahmedabad, Gujarat, and him to guide we are having his mentor, Dr. Sunil Chand, who is associate professor at the Department of Pediatrics in Namo Medical College, Ahmedabad, Gujarat. So I welcome you all, and we will proceed with the blessings of Dr. Yogesh Pari, our Vice President and the brain behind this program. Welcome, sir.
Okay, madam. Thank you very much.
So,
let us start the program.
We are missing Baldev sir. He is busy with his another commitment, but sir will try to join if there is good network. Our flow is generally the presenter will present the case, and all the experts can ask him as like the PG case presentation in our exams, and they guide them wherever he is confused. So it's all yours, Kara ma'am, Meena sir, and Christy ma'am.
Thank you so much, ma'am.
Naresh, you start your sharing of the screen.
Yes, ma'am.
Here other students are there, Dr. Jaldi, Dr. Vaidehi.
Yes.
So they can participate in between.
Yes, in this we also have other students who has joined through platform so that they can also participate in the discussion. So if you want to ask question not to Naresh but to the other students, all the experts can ask them. Dr. Jaldi, Dr. Sagarika, and Dr. Chinmay Desai, they are, and Dr. Vaidehi, these are other students. But Dr. Jaldi and Vaidehi, you need to join through your audio also to participate in the discussion. So it's all between the experts and presenter now. All the best, Naresh.
Thank you, ma'am. Good evening, everyone. All faculties and my seniors are Dr. Sunil Chand, sir. I started the case presentation of nephrotic syndrome. My name is Dr. Naresh Ratwa, third year resident, Narendra Modi Medical College, Ahmedabad. History, informer mother, patient Rani, 1.5-year-old female child residing at Ramol, belong to low socio-economical class, was hospitalized before 15 days with chief complaint of fever, cough, cold since 3 days, swelling over face since 3 days, generalized swelling since 1 day, decreased urination since 1 day. Rani was before 3 days of admission, then starting heavy low-grade fever, which was on and off intermediate without chills and rigor, relieved by medication. After some time, coughing developed, which was dry in nature, non-productive, with no post-tussive vomiting, no paroxysm associated with runny nose. Mother notified puffiness around eye, which was acute onset, and gradually progressed involved periorbital area, increase in morning and decrease in a day, and again reappear in a morning. Since yesterday, she was developed swelling over abdomen and both lower limb, associated with decrease the frequency of urine around 2 to 3 times a day.
Dr. Naresh, can you just stop over here? So with your history of presenting complaints that you have said that there was some URI-like feature and then there was edema and then there was decreased urination. So what are the systems that you feel are involved, could be involved in your differential diagnosis?
My differential diagnosis is, ma'am, edema's pattern is, first is around the eye, then gradually increase in early morning, then subside in daytime, then reappear in morning. Since my an upper respiratory tract infection, two system is involved, ma'am. First is the renal involvement and upper respiratory tract involvement.
Okay, so if I put the question in another way, suppose if any child comes with edema, what are the different organ systems that can be involved, and how would you differentiate one over the other? Are you getting my question?
Yes, ma'am. Ma'am, due to edema, ma'am, first is the cardiac system is involved, then GIT, liver system is involved, then renal system due to edema.
Very good. So it could be either the cardiac involvement that leads to edema, or GI, or renal. Anything else?
And it's, ma'am, acute event allergic angioedema, and malnutrition, suggested of protein allergy malnutrition, quasir core, ma'am.
Okay, so how would you differentiate something cardiac edema versus a renal edema? Any other one who's present here can answer that?
Ma'am, cardiac edema is a dependent part of body in rise in evening. In renal edema, swelling is developed over periorbital area, then gradually decrease during day and increase in morning.
Would any other PG who has joined would want to add to the differentials that he has kept for edema? Dr. Sagarika, no? Or
in cardiac edema, ma'am, difficulty in breathing, difficult breathlessness in one.
Yes, you're right. But can Dr. Sagarika is also a JR, right? Hello.
Yes, ma'am. So Dr. Sagarika, please.
Yes, ma'am.
Can you add?
Ma'am, the starting point of edema, it is different in liver, in kidney and heart. In case of kidney involvement, it starts from upper part of the body, and gradually as the day progresses, it decreases. In case of heart, it first starts from dependent part, and then it decreases. In case of liver, it might start from ascites in the abdomen. Along with it, it has an associated feature of kidney involvement like oliguria or other things. And in case of liver, they will have jaundice or abdominal pain or other things. In case of cardiac, they will have easy fatigability, palpitation, breathlessness, tachypnea, tachycardia.
Very good. The only thing is that you should also remember that myxedema, which is an emergency, also should not be forgotten. Okay. So in this case, Dr. Naresh, which system organ do you think is involved?
Most probably
renal.
So most likely it's renal, because the progression of this swelling is from the eyes first, and then it has increased subsequently. And also there is this history of decreased urine output. So can you tell me what are the causes that can, renal causes that can cause edema in any child?
Ma'am, first is a nephrotic cause, when nephritis, ma'am, post-streptococcal glomerulonephritis.
Good, very good. Anything else?
Focal segmental glomerulonephritis, membrane.
One is nephrotic syndrome. That is very good. Acute nephritic syndrome, very good. Anything else that you can just keep in your mind?
Around the eye. No, ma'am.
Okay, so even children who present with any cause of AKI or CKD, acute on CKD, can also present with this type of edema and the decreased urine output. Okay, but it's right, nephrotic and nephritic syndrome are the common ones. Okay. Go ahead.
No history of hematuria. No history of headache, blurring of vision, cola color urine, burning micturition, itching, chest pain, breathlessness on exertion, sore throat, skin infection, yellowish discoloration of skin. No history of race. No history of any blood transfusion.
Just keep it in this. So can you tell us what are you trying to rule out by asking this negative history?
Ma'am, negative history. First, my probable is a renal environment system. Differential between nephrotic and nephritis. In nephritic syndrome, presented with hematuria, hypertension, and mild edema. So complaint of hematuria.
Can I just, Dr. Sagarika, any other JR who is there? Is this correct? No history of hematuria in the history?
Yes, Dr. Dhaval. Dr. Dhaval, please answer the question of Kara ma'am.
Anybody else can also volunteer. Dr. Sagarika, no history of hematuria.
Ma'am, in history, we cannot use the term, which is medical term of hematuria.
Exactly. Hematuria is actually the presence of blood in the urine. So unless and until you have examined, so when you're writing, you can say cola colored urine or red colored urine. No history of red colored urine. Go ahead, Dr. Naresh, just go ahead.
Yes, ma'am. No history of burning maturation. Rule out the urinary tract infection, ma'am. No history of itching. To rule out any angioedema. No history of allergy. To rule out the angioedema, ma'am. No history of chest pain and breathlessness on accident. Rule out the cardiac involvement, ma'am. No history of sore throat. Rule out the post-glomerular nephritis, ma'am. Streptococcal glomerulonephritis. No history of skin irritation. To rule out the secondary cause of nephrotic syndrome, just like SLE and Henle's colon purpura. No history of yellowish discoloration of skin. To rule out the liver causes, ma'am. No history of vomiting. To rule out the liver causes, ma'am. No history of blood transfusion. To rule out the secondary cause hepatitis B or rule out or secondary cause of nephrotic syndrome, ma'am.
Dr. Naresh?
Yes, ma'am.
Why did you plan to ask for this high colored urine or hematuria? That's what you asked. But still, why did you ask for that cola colored urine? Why do you want to put this in here? What was your differential diagnosis in that you kept in mind when you asked for high colored urine or the cola colored urine, or that the question you put it as a hematuria?
Ma'am, hematuria rule out the hemoglobinopathy, rule out myoglobinuria, to rule out any other.
So already said your initial differentials were the nephrotic and nephritic, right? So yes, you will start from there, right? You will not directly jump to hemoglobinuria. Okay, tell me.
In past history.
Stay with that slide.
Yes, ma'am.
So basically, what Dr. Christie is saying, like suppose if you have, even in the OPD also, or even in the ward when you're admitting a child, or even if it's your examination, you have those three presenting complaints, and out of which edema and decreased urine output were the major ones, right? Otherwise, it was viral URI which precipitated it. And then you have very rightly said that it is your differential is either a nephrotic syndrome. You said most likely it's not the other organs, it is renal, because of the way that the edema has progressed. And then you have said out of this, the most probable diagnosis from your main complaining, the symptoms that you have given is nephrotic and nephritic. So can you tell me what actually are the complications of nephrotic syndrome? Just name few.
Ma'am, complication of nephrotic syndrome, first means hypovolemia and edema. Okay. Second is the infection, ma'am, peritonitis, cellulitis, and pneumonia, ma'am.
Yes.
And thrombolytic complication, ma'am. Cerebral thrombosis, pulmonary vein thrombosis.
And hypertension. Okay. And what
Hypertension.
are the problems of
Hypertension.
nephritic syndrome also? There will be red colored urine or hematuria, but hematuria will be, you would not use this in the history. And there will be again hypertension. So that's why you're asking maybe of this headache and blurring of vision. You wanted to rule out a very severe hypertension. Okay. This hematuria and cola-colored urine, actually maybe you wanted to rule out red colored urine to rule out some glomerular nephritis upfront. Huh? So then after that, after you have ruled out all these, and then maybe you wanted to rule out liver disease. So that's why you're saying history of yellowish discoloration is not there, and so on. So whenever you're taking, you always have a differential upfront with your presenting complaints, so that you will know what negative history you have to take also, so that you will rule out those things, right?
Yes.
Okay. Go ahead.
In past history, patient is no any significant past history of hospitalization. No similar complaint in past. In family history, ma'am, Rani is only child. Father is a 26-year-old industrial worker and mother is a 20-year-old housewife. Patient is belong to low socio-economical class as per revised Kupusamy classification. No history of TB allergy in parents.
So where do you draw your pedigree chart? Would you actually draw a pedigree chart for every child that you take?
Yes, ma'am.
Go ahead.
In birth history, no any significant antenatal history, ma'am. Baby Rani was born is full-term normal vaginal delivery. Birth weight around 2.5 kg. Cry immediately after birth. No any postnatal event. In immunization history, yes, ma'am.
You haven't mentioned anything about the consanguinity. Have you mentioned epidermis?
No, ma'am.
So that's why I was asking for the pedigree part also. Do you think it is important? Both Dr. Christie and I are worried. We want to know whether consanguinity is there or not.
Yes, ma'am.
You know, any other JR can also answer. Do you know why we're a little bit concerned? We want to know whether there is any consanguinity.
Many inherited disease, ma'am. Nephrotic disease is inherited disease like Finnish type congenital nephrotic syndrome.
Yes, you are right.
Syndrome. Pearson syndromes.
Our child is 1.5-year-old.
Yes, ma'am.
Slightly younger. So any child with nephrotic syndrome always will ask for consanguinity. It's usual part of history taking. Okay. For this case, is a child with younger onset of nephrotic syndrome, younger age of onset of nephrotic syndrome. Definitely you have to ask about consanguinity.
Yes, ma'am. In immunization history, patient is vaccinated for age including booster dose. BCG scar is present.
Preferably, in all the cases, if you can write the names of the vaccines that they have received,
Yes,
it is better, because can you just show again that slide which you have written? So name them, because sometimes additional vaccines also are important for us to know. Huh?
Yes, ma'am. Ma'am, in dietary history, patient was given a breastfeeding up to 6 months of age. Then after complementary feeding started, breastfeeding stopped around at 1 year of age. Patient is calorie assumed 8,020 kilocalorie. Required calorie is patient is 1,050 kilocalorie. Deficit calorie is 21%, ma'am. Protein consuming 13 gram. Required protein is 15 gram. Deficit 13%, ma'am. In a development history, a patient is able to run, walk up to the step 1 foot. Patient is draw a vertical lines and make tower 4 cubes. Patient follow a simple command and 3 to 5 meaningful words. Patient copies parents in domestic staff. In developing history, patient is normal develops. On examination, hello.
We can hear. We can hear you. On database, on the history, can you summarize your history and give us a differential diagnosis?
Yes, ma'am. Ma'am, I have, this is the patient Rani, 1.5-year-old female child, belong to low socioeconomic class, with complaint of upper respiratory tract infection and swelling over periorbital puffiness and gradually increase in morning and subside in daytime, then increase reappear in morning. So probably diagnose the renal cause to rule out the nephritics, complaint of rule out hematuria, blurring of vision, headache. My probable diagnosis is nephrotic syndrome.
Dr. Naresh, why did you stress on the low socioeconomic status? Is the nephrotic or nephritic syndrome related to low socioeconomic status?
Hello.
Hello.
Hi.
Am I audible? Dr. Naresh?
Yes, ma'am. Yes, ma'am.
Rather than that, you should have concentrated on the patient one of non-consanguineous marriage, no significant family history of similar illness, and no significant past illness is presented with these complaints. What is this low socioeconomic status coming in? It's coming at least third time now. Yes, what is the importance?
Ma'am, in lower socioeconomic classes, nutrition, other infection is immuno.
I don't think Dr. Jitendra will agree with whatever you're saying. I don't think it should come in the, it should come upfront. Okay. Rather than that, these consanguinity, family histories, past illness, these things should come in your summarization of history. Okay.
Yes.
So, based on your history, whatever you have taken, you think is some of the kidney disease involvement. So, within the renal system, what are your differential diagnosis for this patient?
So differential diagnosis, sir, is first is a nephrotic syndrome, then nephritic syndrome.
How do you differentiate between nephrotic syndrome and nephritic syndrome based on your history taking?
On history taking, sir, differential diagnosis between nephrotic and nephritic syndrome. In nephrotic syndrome, child is present with grossly edema. In nephritic syndrome, mild edema is present. In nephritic syndrome, sir, the patient present with cola color urine, hypertension, In nephritis syndrome, we common in common in nephritis hypertension and hypertension, sir.
Hypertension, you will realize on physical examination. No, I'm asking based on history.
History. No, in nephrotic syndrome, edema, pattern of edema is generalized edema, sir. Age-wise, nephrotic syndrome is present in 2 to 6 years. In nephritis syndrome, age of most common in 5 years to 16 years, sir. On examination, blurring of vision and headache is present in nephritis syndrome.
Anything else?
Okay. No, sir.
Anyone else from postgraduates? What are the other things which can help in differentiating between nephrotic and nephritic syndrome?
Hematuria is present in nephritic syndrome. In nephrotic syndrome, hematuria is uncommon, sir.
Okay, anything else? So one of the classical thing which would help you differentiating between nephrotic and nephritic syndrome, that nephrotic syndrome usually don't have decrease in urine output.
Yes, sir.
Okay, you can go ahead now.
On examination, I examine Rani with proper light and exposure. She is alert, playful, and sitting in mother's lap. On examination, temperature is normal. Radial pulse is well palpable. Respiratory rate around 26 per minute. Heart rate is 100.2 beats per minute. SpO2 99% on pulse oximeter. Capillary refilling time is less than 3 seconds. BP blood pressure is 50 to 90 centiles, sir. And anthropometry, weight is 9.6 on WHO growth chart. Third to 50th centile. Length is 84 centimeter, 50 to 19 centiles. Head circumference around 48 centimeter, 3 to 50 centile. Mid upper arm circumference is 13.5 centimeter. Weight for length in WHO growth chart is 3rd to 50th centile. Abdominal gut is 43 centimeter. Is
this the appropriate way to interpret weight in this patient?
Appropriate weight 1.5 year. So appropriate weight is 11 kg, sir.
So another.
No, I'm asking that is whatever you have written the weight centiles. Is this the appropriate way which you should be describing weight in the patient with nephrotic syndrome?
No,
Will
sir.
you be able to measure the weight correctly with this edema?
No, sir. No, ma'am.
Ideally, you should mention that this weight is with edema, and obviously you can't interpret, the centile whenever patient is in relapse stage, because you have a lot of fluid in the body.
Yes,
extra
sir.
fluid. So this is not the appropriate interpretation of your weight. So does it weight for length?
Yes, sir.
Which are the charts that you know of to see this weight, length?
WHO and Indian Academy of Pediatric growth chart, ma'am. 1 to 5 year, female and girl, and 6 to 18 year.
So in less than 5 years of children, which of the chart you are supposed to use?
Sir, WHO charting, sir. Growth chart.
Okay.
In age in a month and height in centimeter.
Okay, go ahead.
On head to toe examination, head is a normal size. Hair is a black and thin. A periorbital puffiness present in a face. In oral examination, no ulcer, no candidiasis, and no gum bleeding. No iterus or pallar in eyes. Ear is nose, no normal. Chest, no abnormality, abnormality in chest. Abdominal distension is present. Spine is normal. Bilateral lower bib edema is present. Genital area is no edema. No any skin lesion. No anemia, jaundice, clubbing, and lymphadenopathy. On systemic.
What is the importance of head-to-foot examination in case of a child with the first episode of nephrotic syndrome?
Ma'am, in nephroticism, patient in nephroticism in Gowel-Bowart syndrome, present in congenital nephrotic syndrome microcephaly. So head is important, ma'am.
Good. Then
ma'am, facial puffiness is common in nephrotic syndrome. On oral examination on patient on steroid therapy, candidiasis infection present in oral cavity.
Steroid. We haven't started steroid yet, right?
Yes, ma'am.
Okay.
In one patient on steroid, growth velocity is decreased. Patient is a short stature, ma'am. Abdominal distension in present in nephrotic syndrome. On edema is
yeah, mentioned only edema.
Yes, ma'am.
You should have told it's normal or it's ambiguous. Basically, in case of first episode of nephrotic syndrome, we want to rule out any syndromic causes associated with nephrotic syndrome or any monogenic causes associated with other structural malformations.
Yes.
One, you said Galloway-Mowat.
In IMM microchoria in Pearson syndrome, ma'am.
Yes, you're right. Ambiguous genitalia.
Ambiguous genitalia present in Dennis Dress syndrome, ma'am.
Very good. Okay, you can proceed.
Just a second. So one is that this head to toe will help you in ruling out any syndromic causes. What is the importance of lymphadenopathy? Can anybody else also answer? I think Dr. Naresh is speaking all the time. So lymphadenopathy, anybody? No one?
Ma'am, is the tuberculosis, ma'am, lymphadenopathy present?
Yes, one is that lymph nodes, like you should examine the child for lymph nodes, because if there is tuberculosis, then you may have to treat the tuberculosis first. Another one, very good. If you read associations, so sometimes Hodgkin's lymphoma can present with nephrotic range proteinuria. So this is one very simple, it is rare, but there are cases, there are case series. So just look out for the lymph nodes, because if you miss a lymphoma and you give steroids, then you all know what will happen. So lymphadenopathy is also something that you should really stress when you are examining the patient. And also, like Christy ma'am said, that you have to look out for syndromic syndromic features. Just go ahead then. Thank you.
Yes, ma'am.
Ma'am, I want to ask about skin lesion. Why did you specifically mention that there was no any skin lesions there, no skin lesions?
Ma'am, SLE-like syndrome presented with skin rashes, joint pain. A secondary cause of nephrotic syndrome, Handler's colon purpura.
Our child is slightly younger age, but still you can ask. What is the other systemic disease that can present as nephrotic syndrome? Which is a slightly older children presents with typical skin lesions.
Yes, ma'am.
You always ask it with SLE.
Yes.
It's like vasculitis. What type of vasculitis? I'm giving you a clue. The lesions are usually present in the dependent areas, lower limb.
No, ma'am.
Dr. Gawar? Oh my God. It's not Kawasaki. You are near to somewhere near it is. The common, most common vasculitis of childhood is Kawasaki, or it's the alternate. Have you heard of IgA vasculitis, or previously called HSP?
Yes, ma'am.
Okay, go ahead.
In systemic examination, per abdominal examination, first is infection. Patient is generalized abdominal distension with no dilation, tortuous vein visible. Umbilicus vein is everted, transversely stretched, no scar and herniation over the abdomen. In palpation, superficial palpation and deep palpation. Superficial palpation, no tenderness and no rebound tenderness. Abdominal wall edema is present. In deep palpation, no arachnomegaly is present. A septic dullness is present. No fluid thrill and no postnasal dullness present. In respiratory system, bilateral equal air entry present. No crepitation or wheezing in respiratory system. In cardiovascular system, S1, S2 is present with no murmur. In CNS, child is awake and alert.
Harish, you should mention S1, S2 is whether it is normal or not. You cannot mention whether S1, S2 is present or not. What is horseshoe dullness? I am hearing it for the first time. Will you just enlighten me?
Hello?
What is horseshoe dullness?
Ma'am, horse. I'm serious.
I'm hearing it for the first time. That's why I just want to know what is it. Anyone else can explain also. If Dr. Dawal or who else is there? Is it usually used? Who else is there?
Ma'am, in case of mild to moderate ascites, we find dullness in the shape of horseshoe in the lower part of the abdomen on percussion. So, shape of horseshoe, that's why it's called as a horseshoe dullness.
Okay. Thank you. I am hearing it for the first time, so never heard before. Thank you for.
Yeah, even I have never heard, and actually, meaning. I think they should follow Hutchinson's, and explain the physical examination according to that. Preferably, because these terms and may not be very common, and so if you have an examiner from a different part of the country, maybe we're not so used to this, so then we'll be very today both Dr. Christie and I are a little bit, we've not heard of it. So maybe you should choose something like Hutchinson's and go with it. Shifting dullness is understood by one and all, even if you go abroad also. So I think that would be better, but otherwise it would depend on your examiners also. Okay. You want to do, meaning just because we're thinking the differential diagnosis is nephrotic, do you feel that CNS examination only awake and alert would do, or would you want to do the whole examination, and why have you?
Important of CNS examination. Any congenital nephrotic syndrome, Gallot-Mobile syndrome is developmental delay, and and complication of nephrotic syndrome, thrombosis of the cerebral vein, hypertension.
Yeah, so actually, see, suppose if you're having a nephrotic syndrome child, or a nephritic syndrome, you are keeping these two differentials, right? So you know that with hypertension, also anything can be there, and you also said thrombosis also at one point of time, right?
Yes, ma'am.
You only have said, right? So when a child comes to you, regardless, especially if it is the first time that you're seeing the child, regardless of whatever system you're thinking is involved, you have to do all the other examination. I am happy that you kept the abdominal examination first, because there is where the ascites is, there is where you'll get the shifting dullness, okay? But I don't think you can do a shortcut of the respiratory, the CVS or the CNS examination. They have their own importance in this, like especially the CNS, you have really cut it short. Like I would actually want to know whether the child is actually neurologically normal. What do you say, Dr. Jitendra and Dr. Chrissy? Can we just leave CNS like awake and alert?
I think, ma'am, all systems should be at least mentioned. What is the upper respiratory? At least you should say the upper respiratory. The patient presented with URI only, URI, right? So what is the upper respiratory tract? What is the lower respiratory tract? You have to at least mention the important things in each system. It's not enough. I do agree with Karan.
Plus, I know that this is the first, probably the first time patient coming, but he does have edema, so there might be complication related to edema as well. So you can't, there might be, the lower respiratory tract infection, or there might be pleural effusion if you are thinking it just like hypoalbuminic state. So obviously one need to carefully examine all these systems.
Yes.
Go ahead, Dr. Naresh.
Yes, ma'am. In summary, the case of 1.5-year-old female child coming from low socioeconomic class, having complaint of swelling around eye, then after progress, lower limb and abdomen associated with upper respiratory tract infection since 3 days, with no significant past history, family history, and birth history, with normal developed and vaccinated for age. On examination, puffiness around eye and face, abdominal distension with lower lip edema. On systemic examination, septic dullness is present. Other sign is NAD. So my probable diagnosis is the first episode of idiopathic nephrotic syndrome, probably minimal chain nephrotic syndrome without any complication, vaccinated for age and normal developed child.
So you're saying normal developed child, huh?
Yes.
You've taken the history, that is fine. But did you do the DST to actually say ki that the child's development is normal? So you get our point when we're saying ki that you have to examine everything. It has to be complete. Otherwise, only history, the child is developmentally normal, but you have not examined it. It's really true or not, right?
Yes, ma'am.
You got our idea ki why we want the whole examination to be done of a patient who presents to you for the first time, and preferably every time they come to you, if you have the time and the logistics are okay, better to always revise your diagnosis, see the patient all over again. Okay.
Yes, ma'am.
Why you have written the minimum chain nephrotic syndrome?
Sir,
based on history, can you identify the underlying histopathology?
In minimal chain nephrotic syndrome, sir, pathology is the podocytopathy.
No. What I'm trying to ask, based on your clinical evaluation, can you identify the underlying histology that you have written is case of minimal chain nephrotic syndrome? Why not focal segmental glomerulosclerosis? Or
sir,
why
most
not
common is minimal chain with focal segment is the most commonly steroid resistant focal segment.
We haven't given
this is the patient coming first time to you.
First time.
So how do you know that whether it's steroid sensitive or it's steroid resistant?
Not.
What proportion of patient who is coming to your first episode nephrotic syndrome have minimal chain disease?
Respond to steroid therapy, minimal chain disease, sir. Relapse is recurrent.
No, my question is that what proportion of patient who is coming at this age will have 80%. Minimal chain disease?
80%. In this age group, 80% chance of minimal chain nephrotic syndrome.
80% is probably a bit too high. Maybe 70% because this is a bit younger of age and you might have the other underlying histology as well. So what's the typical age of presentation of minimal chain nephrotic syndrome?
Around 2 years, sir. 2 to 6 years.
But this child is 1.5 years, right?
Yes, ma'am.
So why are you unnecessarily troubling yourself by saying probably it is MCNS?
Yes.
First of all, you're not even like, you can keep differential diagnosis of nephrotic syndrome, but obviously without, investigations, you can't 100% say that this patient is nephrotic syndrome.
Yes, sir.
Upon that, you are also committing that is, the minimal chain nephrotic syndrome. So based on clinical evaluation, obviously one can't say that is, minimal chain disease. So if you have to proceed from now onwards, tell us the 3, investigations which you want to do to confirm your diagnosis of nephrotic syndrome.
First, to confirm the diagnosis, investigation done is urinolysis, urine RM, and urine CS. CBC, sir. And confirm.
Carefully listen to our question. I have asked that tell us the 3 investigations which you want to do to confirm diagnosis of nephrotic syndrome.
Confirm diagnosis, sir. Urine dipstick test in early morning sample, urine protein create ratio, sir, spot urine protein create ratio, and 24-hour urinary protein create ratio, serum albumin, and cholesterol.
So what are the criteria to diagnose nephrotic syndrome based on these investigation?
Criteria of nephrotic syndrome, nephrotic range protein urea, sir, more than 3+ in dipstick in early morning sample, in urine protein ratio more than 2 mg per deciliter, and urinary excretion protein in more than 40 milligram per meter square per hour, or more than 1000 milligram per day, sir. And hypoalbuminemia less than 3 gram, and edema and hyperlipidemia more than 2 milligram per deciliter.
More than?
Edema and hyperlipidemia more than 2 milligram per deciliter.
Hyperlipidemia you defined by more than 2 milligram per deciliter.
2 milligram of what?
More than 200 milligram per deciliter.
Serum?
Serum cholesterol level.
Okay. How will you define hypoalbuminemia?
Ma'am, hypoalbuminemia is the urine serum albumin less than 3.5 gram.
Less than 3.5 gram or less than 3 gram per deciliter?
In 2020 guidelines, Indian Academy, less than 3 grams, sir.
Indian Academy of Pediatric Nephrology guideline, what's the current criteria for defining nephrotic syndrome?
Proteinuria, hypoalbuminemia, and edema.
Okay, so you don't need to have essentially the hypertriglyceridemia or hyperlipidemia to define nephrotic syndrome. Okay.
Yes, sir.
Any other test you want to do in the first episode of nephrotic syndrome?
So diagnosis first to urine dipstick, urine RM.
So whatever you have, tell us apart from whatever you have already enumerated.
Sir, first is septic screen rule out, CBC, CRP, and then tuberculosis. Rule out the TB, tuberculosis test is done.
You need CRP levels in each and every patient with nephrotic syndrome?
No, sir.
Then why you are saying that you need to do CRP?
Rule out the septic screen.
Every patient with nephrotic syndrome is not septic, no? So you need
Yes,
to decide that based on your clinical evaluation.
Yes, sir.
So probably in our country, which is where tuberculosis prevalence is high, we need to do Montague's test.
Yes, sir. Empty dish.
So once you have confirmed diagnosis of nephrotic syndrome, so apart from the protein, you would also need to look at the urine routine microscope. Urine routine microscopy.
Renal function test.
You have to look for microscopic hematuria. You have said there is no gross hematuria, right? No high colored urine or cola colored urine.
Yes.
But still you have to look for RBCs in the urine.
So, ma'am, hematuria is more than 5 RBC in high power field in uncentrifugal urine. RBC 2 to 3 is not a significant.
Uncentrifuge.
Hello.
It's a centrifuge sample.
more than 5 RBC in high power in centrifugal.
Okay. Go ahead. What other investigation? You will do Manto to rule out what?
Mantox test rule out for tuberculosis.
Tuberculosis. Active TB.
Means in nephrotic to start steroid therapy to flare up for infection.
So
to rule out.
Manto will rule out active TB.
No,
or you want to rule out something else? You have to rule out active TB by taking history, clinical examination, maybe by an X-ray. You will do Manto for something else. You will look for latent TB in the child by doing the Manto. Okay. Your other close differential diagnosis was nephritic syndrome, right? So you will definitely look for microscopic hematuria. What else will you do?
Microscopic hematuria.
What other investigations you want to do?
Renal USG for USG for gross hematuria, urine RM, urine routine microscopy.
Important blood investigation, you are suspecting a renal disease in this child, right? Blood investigation.
Renal function test, like urea create and electrolytes.
Yes, Sagarika.
Urea creates and electrolytes.
To rule out the nephrotic syndrome, complement C3 level.
In the first episode of nephrotic syndrome, you probably don't need C3 level until unless you find anything abnormal with your, either RBC or WBC in urine or RBC cause, or if your creatinine in the range, then you might suspect, something beyond nephrotic syndrome. So all patients with the initial episode of nephrotic syndrome don't require complement passage. So once you are done with initial evaluation and confirm the initial first episode of nephrotic syndrome, how will you treat it?
Sir, first episode of nephrotic syndrome, treat with rule out the septic. We start a prednisolone 2 milligram per kg per day or 16 milligram per meter square per day. Hello?
Yeah.
For 6 weeks. Then alternative day therapy for 1.5 milligram per kg per alternative day for 6 weeks. Sir.
Okay. So suppose like this patient initially had, presented with cough, coryza, fever. And if on throat examination you find, some congestion,
yes,
what would be your further plan? Whether you would treat the nephrotic syndrome first or you would treat the upper respiratory tract infection first?
Sir, upper respiratory tract precipitated the nephrotic syndrome. So first treated the upper respiratory tract infection.
Okay. Any other drugs which you want to prescribe apart from prednisolone for first episode nephrotic syndrome?
No, sir. First episode of nephrotic is to start pregnancy only.
So when you encounter this kind of patient in outpatient basis, what other advice you will give to parents apart from the prednisolone medication that they need to take it daily for 6 weeks followed by alternate day for 6 weeks?
The advice for parents is started prednisolone 2 milligram per kg per day early in morning with after foods with use antacid, sir. And monitoring follow-up is weight monitoring, AG monitoring, blood pressure monitoring, and a urine dipstick.
Anything else? So you don't need to prescribe antacid to each and every patient unless they have, symptoms of gastritis or dyspepsia.
Yes, sir.
Second thing that you need to, tell parents that once they start steroid, there obviously, would be some chubbiness in the face, and parents might confuse this thing with swelling. So you need to tell them the approximately time to remission. And obviously you need to advise them the dipstick monitoring, that they need to monitor urine protein in early morning first urine. And they need to document it in a urine protein diary.
Yes. Yes.
So what is the expected time to remission in a patient with first episode nephrotic syndrome?
Around 5 to 7 days. Remission around 5 to 7 days after started prednisolone therapy.
Isn't that too early?
Hello?
So what proportion of patient would achieve remission in 5 to 7 days? Everybody would achieve remission in 5 to 7 days?
No idea, sir.
Any other postgraduate students?
Sir, it can take 14 days to 20 days to take full remission.
Any better answers from anybody else? So how do you define remission?
Sir, urine dipstick, trace or nil for 3 consecutive days. Or urine protein create ratio less than 2.
Less than 2?
0.2. Less than 0.2.
So when you, like some parents would ask you when you prescribe prednisolone, that what is the likelihood that their kid would achieve remission with this steroid? What proportion of patient would achieve remission with prednisolone?
No, sir.
No idea?
No idea, sir.
Anybody else from postgraduate residents? So if you overall look at the overall nephrotic syndrome, the steroid sensitivity is around somewhere 80%. It might be 5% here and there, depending on the, might vary bit of the country and studies. So roughly around 80% of nephrotic syndrome would respond to steroid, and 15 to 20% would have steroid resistant nephrotic syndrome.
Yes, sir.
Time to remission, if you look at carefully, almost 50 to 60% would achieve remission by 2 weeks. But it may take up to 4 to 6 weeks of duration to achieve complete remission in some of the patients. So it's not always that in 5 to 7 days everybody would achieve remission.
Yes.
So how do you define the steroid-resistant nephrotic syndrome?
Sir, steroid-resistant nephrotic syndrome defined by do not achieve remission after 6 weeks of prednisolone therapy.
Okay. So, Dr. Naresh, I think you've been answering a lot of questions, right? Yeah. So, but I think for the benefit of all the PG students who are here, please go and read again the recommendations of the Indian Society of Pediatric Nephrology. The definition is very important, which is nephrotic range proteinuria, hypoalbuminemia, and edema. And whatever Dr. Jitender had asked, what are the few investigations that you will do, like in this child at the first time that she has come to you, and so what are the essential investigations? So both Dr. Christie and Dr. Jitender have told that urine analysis is very important. It is not only the spot protein creatinine ratio that is important. It is also the urine RE, because you have to see for hematuria, right? You do a complete blood count. You also do blood urea and serum creatinine for the simple reason that it's a renal disease. So you would want to know the baseline. You would want to know the serum albumin and the total cholesterol. And because Dr. Jitender said the tuberculosis is common, so you screen out by doing a tuberculin test. Okay?
Yes.
Yeah. So then also those other additional evaluation will depend, like suppose a chest x-ray, you'll do only if there's a positive tuberculin test or history of contact. Ultrasound, you'll do only if you think that if there is gross hematuria, or you're thinking that it's some other disease, meaning systemic disease, C3, C4 also, like Dr. Jitender has said. Okay, so those are the additional investigations. The most important that you have to remember is urine analysis, spot protein creatinine ratio, urine RE. That is urine analysis, complete blood count, blood urea serum creatinine, albumin and cholesterol, and a tuberculin test, right? Then Dr. Jitender had also asked you what is the treatment that you have to give. You've rightly said that it is prednisolone, which is 2 mg per kg per day for 6 weeks, followed by 1.5 mg per kg alternate days for 6 weeks, you said. And Dr. Jitender also said, please do not use antacids for each and every child. Dr. Jitender had also told you that you all should counsel the parents that almost 85 to 90% will respond to steroids, and that it will take some time for the steroids to act. So they should not be panicky if the child does not go into remission, and then to check the urine protein. So suppose if somebody cannot afford to buy the urine dipstick, is there any method that you think you can tell the parents to do? Check for proteinuria disappearance. Primitive way, though it is only 300 rupees per whole box.
Is it, ma'am, heat coagulation?
Yes. So your biochemistry classes will help. So you can do that heat coagulation test. Very good. So in a first episode of nephrotic syndrome, one is that you're giving steroids. The other thing is that you're counseling the child, which is very important. And counseling that they should take the whole 6 weeks of full dose and 6 weeks of alternate days. Otherwise, there are more chances of relapse and complications afterwards. This is very important, because what we find is that by the time they come to us, they hardly, meaning the pediatricians do not give the full 6 weeks and another 6 weeks of alternate days. Okay, so you have to counsel that if you give this 6 weeks of full dose steroids and 1.5 alternate days of 6 weeks again of steroids, the chances of relapse will be less. Okay, so this is important. What other management would you do, like in your particular child, where in this particular child? One, you've said ki you'll counsel the child, you'll tell the parents to keep the monitoring of the proteinuria, then you're giving steroids. You do not need antacids upfront. Anything else that you would like to do in the management?
Dietary advice.
Yes, exactly. So that is very important, because as pediatricians, growth, development, vaccination, these are very vital for any this thing. So how would you, suppose you have taken this and you've said that there's almost 20% calorie deficit and some other, I don't remember the exact percentage of protein deficit. So how would you counsel the parents?
Ma'am, low salt diet, 1 to 1.5 milliequivalent per kg per day. Low salt diet in papad, pickles, potato chips, cheese, and bread. To avoid it, unsaturated fatty acid, less than 30% on recommended daily allowance.
How will you tell it to the parents? Even I cannot understand what you're saying. So can you tell in the way that you will tell the parents?
To avoid salt restriction,
Dr. Naresh, can you tell in the Hindi?
Yes, sir.
Yeah. Counsel the parents in the Hindi.
Yes, sir. Parents counseling. बेन खाने में ध्यान रखने का है कि ज्यादा मीठे वाला मीन्स पापड़ हो, अथाना हो, मीन्स जे नमक वाला हो, ज्यादा ऊपर से नमक डालना नहीं है बेन। बाहर की चीजों से जो होती है वो पोटैटो चिप्स खाने का नहीं है, और बैलेंस yes sir.
I think Dr. Jitendra will have to help me because I cannot understand Hindi properly. Hello?
Hello?
Yes, basically, the preserved foods, all the preserved foods and all the extra salt should not be given. Okay. Then how do you increase the protein intake?
Ma'am, high protein diet, eggs.
Dr. Chinmay, Dr. Aarti, and Dr. Sagarika, can you help the Dr. Rathwar?
Yes.
Sorry for the diet, sir. Hello.
Yeah, Chinmay, please.
Yeah, well,
you can mention in the English
Madam
also.
pointed out rightly that the preserved food, pickles, packed chips, and these things, the parents should be counseled that should be restricted from the child. Protein-rich foods, according to dietary habits of the family, should be prescribed for non-vegetarian who the family consumes non-vegetarian diet. Egg whites, removing the yellow of the egg. Whites should be prescribed. Also, lean meats, fat-free lean meat should be prescribed for a non-vegetarian diet family. For those following a vegetarian regime, they should be prescribed lentils, nuts, also dairy. If they're lacto-vegetarian, dairy should be prescribed. Low-fat yogurt, low-fat milk should be recommended.
So basically what I always tell at least my residents is that whenever you're taking that diet history, so most likely it will be by 24-hour recall pre the illness, right? So so what you do is that you improve on that, because suppose if the calorie intake is less, so instead of giving chapatis, you tell them to make them into paneer parathas. Then meaning whatever dal they're taking, suppose if there's too much of water, then you decrease the water there and then give a more thicker version of the dal, so to increase the protein intake. Then eggs, most, meaning if they take, that's fine, they can take that. So things like that. It cannot be like whatever question I'm asking actually is not like for everyone, but you'll have to see with every child, and this will come only if you're taking a good dietary history and then try to calculate how much is the protein and calorie intake, and then on top of that, you know how to improve the protein and the calories of that particular child. So, you know, somebody living in Gujarat may be different from somebody living in the Chandigarh, and different in Calcutta. Maybe they'll be having fish or something like that. So whatever local things that they have, no, you try to improve on that. Because if you send to most of the dietitians, what they'll do is they'll add on all those those protein products, which actually adds to the cost and are not as good as natural food. So that dietary history that you took, no, it is very important, and on that try to improve the calories and the proteins, because improving the nutrition in the child is also very important. Is it clear, Dr.?
Yes, ma'am.
Dr. Naresh, you have prescribed steroid for this patient. Probably by the 21st day or 14th day, the child has attained remission. You will complete the 6+6 weeks therapy. And yes, what is the counseling that you will give to the parents? Like, is this disease prone to recur or it will not recur? What's the chance of recurrence? Or what do you mean by relapse?
Ma'am, chance of recurrence counsel is chance recurrence to
any of these steroid sensitive kids will recur. Suppose you have 100 kids. You can just tell the percentage.
No, ma'am, no.
It's like more than 70 will recur. Only around 20% kids have a single episode of nephrotic syndrome. So suppose you have a steroid sensitive child and this child is almost 1.5-year-old child. More than half will have steroid dependent or frequent relapsing course. 20 to 30 will have infrequent relapsing course. Okay.
Yes, ma'am.
So you have to definitely counsel about that. So more than half will have a frequent relapsing or steroid dependent course. 70
steroid
will have a recurrence.
Yes, ma'am.
How do you define relapse?
Ma'am, relapse after the treatment of prednisolone, completely treatment of prednisolone, dipstick more than
you want to modify it
in 3 consecutive days.
You want to complete the therapy?
Yes, ma'am.
Are you sure? Can relapse occur in tapering dose of steroids?
Yes,
Or
ma'am.
alternative steroid?
Yes, ma'am.
You want to modify your answer?
After initial
After
therapy.
completion of therapy.
Initial therapy.
Suppose you have a child who had attained remission on 6 weeks of daily therapy and the patient relapses on 6 weeks alternate day therapy or in the 4th week of alternate day therapy. Will that be considered relapse, or you will wait till the completion of the first episode therapy to label it as relapse?
Steroid dependence, ma'am. After 6 weeks of then on alternative day therapy, relapse of dependence.
Just tell me what is the definition of relapse.
Urine dipstick more than 3% for 3 consecutive days after initial therapy.
After attainment of remission, do you want to say that?
At the time of this, yes, ma'am.
The patient has attained remission of I already said that your child has attained remission. On follow-up, if the patient is having proteinuria amounting to nephrotic range of proteinuria, then we will call it as relapse.
Yeah.
So how will you define nephrotic range of proteinuria? You have already said that in the
Yes,
previous questions. How will you define relapse then? Will you modify your answer again and tell once again?
When proteinuria more than 3 plus on 3 consecutive days after the remission.
Okay. How will you define, how will you treat relapses?
Ma'am, relapse treat first prednisolone 2 mg per kg per day till remission. After the remission for 3 consecutive days, then tablet prednisolone alternative day 1.5 milligram per kg per day for 4 weeks.
Okay. If the patient is not attaining remission, in how many days will you define resistance in the first relapse? So your patient is having first relapse, you have initiated the steroids. When will you define resistance in this child, steroid resistance in this child?
Man, more than 2 relapse in 6 months.
Resistance. I'm asking about resistance.
Resistance. Ma'am,
on your child is on first relapse therapy.
Yes, ma'am. Ma'am, after 6 weeks, of prednisolone 2 mg per kg, do not attend remission.
That definition stands here also. Okay, you have completed the relapse therapy. The child has attained remission and you have converted to 1.5 mg per kg steroids and the patient attained, you have completed the therapy. Okay, how will you define frequent relapse?
Ma'am, frequent relapse is more than 2 relapse in 6 months or more than 4 relapse in 1 year. Hello.
Anyone else wants to answer?
More than 2 relapse in a 6 month or 3 relapse in a whole year.
Ma'am, more than or equal to 2 relapse of 6 months of treatment.
Hello. More than 2 relapse in 6-month treatment, and more than 3 in any 6 months, and more than 4 in 1 year.
4 or more in 1 year. First,
yes.
First 6 months after initial therapy, if the patient is relapsing back to back, 2 relapses are there, you can call it as frequent relapsing. Yes. What's the definition of steroid dependence?
Steroid dependence. Ma'am, 2 relapse on alternative day therapy, or within 14 days after stop steroid.
Most importantly, 2 consecutive relapses.
Yes, 2 consecutive.
Okay. So if your patient is developing the first relapse on tapering steroid therapy or alternate day therapy, it is not steroid dependence. You said that if the patient is relapsing in the 6 weeks alternate therapy, it is steroid dependence, right? Initially, you said something like that. It's not steroid dependence. If the patient is relapsing back to back on tapering steroids or within 14 days of stopping steroid, then only it becomes steroid dependence. Okay, what is the importance of identifying frequent relapses and steroid dependence?
Ma'am, choose the threshold or steroid toxicity.
So these patients will have multiple relapses, and the patients may need to be given high dose steroids frequently, and they are prone to get steroid toxicity. To prevent steroid toxicity and adequately manage the relapses, we need to identify and classify these patients.
Yes, ma'am.
Other than steroid, which are the alternative medications that you know of?
Ma'am, alternative medication is levamisole, myophenolate methyltyl cyclophosphamide. And other, if not response to cyclosporin or tacrolimus, is not respond to rituximab.
Karama?
Hello.
Okay.
Hello.
Have you used levamisole? When will you use levamisole? What's the dose?
Ma'am, levamisole dose is 2 to 2.5 milligram per kg per day for 2 divided.
2 divided. We give it a single dose. Alternate day, right?
Alternative, ma'am.
Okay. When will you prefer levamisole?
Ma'am, if a threshold relapse on threshold less than 0.5 milligram per kg on steroid, to low dose of steroid 0.5 to 0.7, alternative they with add levamisole, ma'am.
How will you decide which alternative medications need to be given to the patient?
No idea, ma'am.
What all the basic things you will check, you will look for?
Any other resident?
Of the disease. Oh, sorry.
Any other resident which can answer Dr. Christie's question? That
Dr. Sagarika, you want to answer? How will you decide which alternative medication you want to give to the child? You have a steroid-dependent nephrotic syndrome, or you have a frequent relapse in nephrotic syndrome. Our child started at 1.5 years of age, and by 2.5 years, Now he is having either steroid dependence of FR. How will you decide on the steroid sparing agent? Dr. Sagarika, you want to answer that question? Dr. Chinmay. Depend upon the patient's.
Ma'am,
Okay.
I would like to try. Ma'am, we have for the patient who is undergoing frequent relapses and who is still steroid dependent. What could be done is if the patient is put on when the patient is put on long term, say steroid therapy, and the patient is developing corticosteroid adverse effects, we could consider these steroid sparing agents such as levamisole, cyclophosphamide, micro.
Very good. We will look for steroid toxicity. Okay. Then what?
And also, ma'am, if for the first line, we could go for these agents like levamisole and cyclophosphamide. If these also do not provide a clinical response, we could go for calcineurin inhibitors such as tacrolimus and cyclosporin.
Well, look at the drug's efficacy. What is the, if the patient is steroid dependent, we look whether the patient, what is the threshold of steroid dependent. We will look at the cost of the drug. What is the side effect profile of the drug? What is the way of administration of the drug? What is the patient's preference? What is the parent's preference? These things we will address before deciding on the steroid sparing agent or the, what you said, the long-term alternative therapy. At least you have to look at the steroid toxicity. If the patient is steroid dependent, you have to look at the threshold of the drug. You have to look at the drug that you are going to prefer. If it's levamisole, what is the efficacy? What is, if it is MMF, what is the efficacy? What is the side effect profile like? What is the mode of administration like? Is the patient compliant? What is the parent's preference? These things also, the age of the child is also important. These things we'll consider before giving or before suggesting a steroid sparing agent.
So can anyone tell what are the various side effects of steroids and how, meaning, you just named the side effects of steroids.
The side effect of steroid is the cusinoid phases, obesity, hysteria is present, ma'am, hypertension, glucose intolerance, ma'am, cataract, ma'am, and osteoporosis, ma'am.
Besides cataract, anything in the eye?
Posterior capsular sublenticular.
Besides cataract, I agree with you. Cataract, anything else?
Maybe glaucoma could present that way.
So it is important for any child who's on prolonged steroids to be examined not only for cataract, but also for the intraocular pressure, because glaucoma is there, yeah? So, sir, do you think we can wind up, or Neha ma'am, do you think we should wind up, or you want to answer few or questions?
No, so ma'am, it's all in experts' hand, how much to ask and when you want to wind up. So, Naresh, will you please stop the screen sharing?
Yes, ma'am.
If they have more questions like this, then they should prepare for DM Pediatric Nephrology, available in PGI.
It's a very good interaction, I must say. All the questions that Naresh, you also tried to give them the proper answers, and the experts also guided in wherever the you are confused, but I want more participation from other students. So today, most of the students were silent. I request you all and also ask your other friends to participate in this and to answer the questions of the our experts, so that the exams will be more smooth. Anyhow, I congratulate Naresh for the excellent presentation, and I thank all the experts, Dr. Kara ma'am, Dr. Christy ma'am, and the Meena sir, for your presence, for your guidance, and accepting our invitation. I also congratulate Dr. Sunil Chand for preparing Naresh so well that though I found him somewhat थोड़ा सा डरा हुआ था, but he tried well and he also answered well. Thank you so much. Yogesh sir, any words from you? So, okay, once again, thank you so much, Clarinet platform, for giving us this opportunity and the platform. And thank you all the experts. Thank you so much. We can close the session.
Thank you, ma'am. Thank you so much. And good night to all. With this, we're closing here. Thank you.
Thank you.